For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey CardioNerds, or howdy CardioNerds, Dan Amether here, and I'm with a group of fantastic physician clinicians from the University of Tennessee in Nashville. Let me turn it over to the first of them, Dr. Neel Patel. Neel, take it away.
Thank you, Dan. Welcome, CardioNerds, to another compelling episode of CardioNerd Case Report podcast. I'm Neel Patel, a second-year fellow from the University of Tennessee, Nashville, and I'm thrilled to be joined by my brilliant co-fellows, Doria and Jay, as we dive into a truly extraordinary case today, one that significantly challenged our diagnostic and management paradigms.
Thanks, Neel. I'm Victoria, also a second-year fellow from the University of Tennessee, Nashville. I'm excited to share this case with our listeners, and it really pushed the boundaries of our understanding of acute aortic pathology.
And I'm Jay, rounding out our team from the University of Tennessee, Nashville. This case is a testament to the unpredictable nature of cardiovascular disease and underscores the critical importance of vigilance and multimodal imaging in acute settings. It's truly an unprecedented anatomical rupture.
So before we jump into the complexities of this case, let's set the stage. So it's Nashville, our home base, such a unique blend of cutting-edge medical advancement and a vibrant cultural backdrop, especially our renowned live music scene. It really fosters a dynamic learning environment where complex cases are approached with both scientific rigor and collaborative spirit.
Absolutely, Neel. It's a great place to learn and practice, but also one of the top bachelorette destinations. But I digress.
So Neel, can you kick us off by introducing our patient and the initial presentation?
Absolutely. So our patient was a 57-year-old male who was brought to a regional community medical center after reportedly being found unconscious. His family and neighbors provided the crucial context, reporting that he was experiencing weakness for several days and an episode of chest pain just prior to his syncopal event. This constellation of symptoms immediately raised concerns about a serious cardiac or neurological emergency, particularly given the found down scenario.
That found down scenario always puts you on high alert. So what was the initial workup at the referring hospital?
So at the referring hospital, a stroke workup was initiated, including the CT of the head and CT angiography of the head and neck, which ultimately proved to be non-conclusive. A urine drug screen was done, which was positive for benzodiazepines, fentanyl, cannabis, and methamphetamine. This finding, of course, introduced a significant element to the patient's social history, adding layers of complexity to the overall clinical picture.
Given the presenting symptoms of chest pain and syncope, I imagine an emergent cardiac workup was also underway.
Precisely. An emergent left heart cath and coronary angiography was performed at the community hospital in the light of elevated high-sensitivity troponin levels. The angiography revealed non-obstructive coronary artery disease with around 40 to 50% lesions in almost all coronary arteries. However, a pivotal observation during this procedure was the straining of the aortic wall upon injections of the RCA, which immediately raised suspicion of an aortic dissection. This finding was crucial, indicating potential underlying aortic pathology that warranted further investigation.
So the angiogram pointed them towards the aorta. What happened next?
Following the angiographic findings, transthoracic 2D echo or TTE was done, which showed a possible pericardial hematoma that prompted a CT angiogram of the aorta, which definitely demonstrated a large saccular ascending aortic aneurysm. Based on this critical imaging finding, patient was transferred to a tertiary care hospital, St. Thomas West, which is our hospital, for further management.
And what about his past medical history? Was there anything that might predispose him to this aortic aneurysm?
Great question, Jay. So his past medical history provided important context. He reported a prior cardiac surgery for a congenital anatomic defect decades ago, which was documented as likely ventricular septal defect. But the further imaging reports, such as cardiac MRI, performed later in our hospital, noted a pericardial patch repair of atrial septal defect. Regardless of the exact congenital defect, the critical information is the history of an open heart surgery decades prior. Such procedures typically involve aortic cannulation for cardiopulmonary bypass, which is a recognized risk factor for subsequent development of iatrogenic aneurysm. This subtle discrepancy in the historical record, while minor in the context of acute rupture, highlights the challenges of obtaining precise medical historical details, particularly events decades in the past or when patients are critically ill and unable to provide clear history. It also underscores the importance of correlating historical accounts with the objective findings from the advanced imaging. The primary implication for this case is the iatrogenic nature of the aneurysm stemming from the prior aortic manipulation, irrespective of the congenital defect repair.
That's a key piece of information. A prior aortic manipulation could certainly create a predisposition.
Exactly. And in addition to a surgical history, patient had a long-standing history of hypertension, as we noted earlier, polysubstance use, including cocaine, methamphetamines, benzodiazepines, opiates, and cannabis. This substance use, particularly the presence of stimulants like cocaine and methamphetamines, presents a significant contributing factor to his vascular pathology. They are not merely comorbidities, but they directly contribute to the vascular damage, and chronic stimulant use can introduce severe uncontrolled hypertension and direct aortic wall injury, thereby significantly increasing the risk of aneurysm formation and rupture, especially when combined with pre-existing conditions like hypertension and prior cardiac surgery. And this represents something we call it as multi-hit phenomenon, where various risk factors converge to create a highly vulnerable vascular system. The presence of these factors emphasizes the critical importance of a thorough social history in a cardiovascular risk assessment, moving beyond the superficial listing of the and understanding the profound pathophysiological impact on vascular health.
So, he arrives at our tertiary center with a large saccular aneurysm. What was the initial management strategy?
Upon arrival at our tertiary care center, the patient was admitted to the cardiovascular intensive care unit, or what we call the CVICU, due to significant hypertension and metabolic encephalopathy. The immediate management focused on hemodynamic stabilization, involving the initiation of esmolol and the cardipine titratable drips to control his blood pressure and heart rate. A repeat CT angiogram of the aorta was performed, which demonstrated a large 6.6 by 6.1 by 5.5 centimeter partially thrombosed anterior ascending aortic saccular aneurysm. This aneurysm was considered likely chronic with layered thrombus, and its formation was attributed to prior cardiac surgery, long-term hypertension, and polysubstance use. Initially, a conservative management approach with aggressive blood pressure control was adopted, considering his recent drug use and the need for further clinical stabilization prior to any high-risk surgical intervention.
And do you want to tell us how did he fare on this conservative approach?
Well, finding this large saccular aneurysm is definitely something that makes you uncomfortable when you first see. And so we called our surgical colleagues and we were making the right preparations for this high-risk surgery. Now, this is not a surgery we want to jump into without caution. So we wanted to make sure the patient was optimized as much as possible beforehand, trying to get his metabolic encephalopathy and his blood pressures and hemodynamics as ideal as possible before. However, on his third day in the ICU, he took a dramatic turn that was unexpected. He had 2 episodes of sustained ventricular tachycardia, necessitating cardioversion and starting him on an amiodarone drip. And this was very unsettling for us and was the beginning of his rapid deterioration in his cardiac status.
Yeah, and just to add on to that, just the night before his planned surgery, he became immediately like hypotensive, bradycardic, requiring immediate initiation of the IV pressors, and he was on 3 pressors at the time. He also required a transcutaneous pacemaker. His blood work at the time, so creatinine bumping up to 2.1 from his baseline 1.0. Troponin levels also skyrocketed to 40,000. And his EKG was also concerning with ST elevations in leads 2, 3, and ABF with reciprocal depressants. So at the time, we were really concerned that what exactly happened. Like this patient was seemingly getting stabilized and we were planning to do this surgery. And all of the sudden, he suddenly decompensated. So the differentials we thought at the time were, is it a STEMI happening considering his ST elevations and troponin elevation? And or is it a rupture of the aneurysm or is it a tamponade physiology, which really prompted us to do emergent transthoracic and transesophageal echocardiogram for him, which were really interesting findings. We did see that his aortic aneurysm had ruptured not just into the pericardium, but directly to the right ventricle, which created a massive shunt from the aorta to the right ventricle, causing the volume and pressure overload into the right ventricle, which was seen on the echocardiographic imaging as a color Doppler flow coming from the aorta to the right ventricle, elevated RV systolic pressure, and it was a truly catastrophic event.
Neel, how interesting. So you're telling me that when you have a patient in ICU who gets decompensated and sick all of a sudden, I love the fact that you went straight to echo. That just provides such a wealth of information and it can really help you when you're in these sticky situations with not a lot of time and need to get some quick information. And what a surprise that this aortic aneurysm had ruptured into the right ventricle. I mean, I've heard of aneurysms rupturing before, but into the right ventricle, I don't think I've ever heard that ever before. Have you ever heard that happening before?
No, and actually I did search PubMed, I did look up about this phenomenon, and I was not able to find any such case report before in which aortic aneurysm ruptured into right ventricle, causing a contained rupture and aortic RV fistula. And that's what makes our case really unique and one of a kind, because not just aortic aneurysm rupturing causing tamponade or sudden decompensation, which is well known, but this is actually the aneurysm rupturing into a cardiac chamber and creating left to right shunt, causing a lot of volume and pressure overload and a sudden pulmonary hypertension. And that's what led to his whole decompensation cascade. So that's what makes it really unique.
So how do you integrate all these findings, the cardiogenic shock, the new EKG findings, massive troponin elevations, and the newly discovered aorto-right ventricular fistula?
The acute deterioration of the patient, characterized by cardiogenic shock, new EKG changes, massive troponin elevation, and the newly discovered aorto-right ventricular fistula, necessitated a comprehensive synthesis of all clinical data. The immediate and overwhelming concern was the ruptured aneurysm and the new fistula, which directly explained the acute right ventricular overload and cardiogenic shock. While other causes of right ventricular failure in a critical ill patient, such as massive pulmonary embolism, acute right ventricular infarction, or acute severe tricuspid regurgitation, were also considered, the echocardiographic findings, specifically the continuous flow from the aorta into the right ventricle, unequivocally identify the fistula as the primary driver of this acute decompensation. The initial concern for acute coronary syndrome, while valid given his troponin and EKG changes, was recontextualized as severe demand ischemia resulting from profound systemic hypoperfusion and overwhelming right ventricular strain, rather than a primary coronary occlusion. This integration of all data points was crucial for understanding the evolving pathophysiology and the primary driver of the hemodynamic collapse.
That integration of the data point is crucial for understanding the evolving pathophysiology. And Jay, what about the pathology of the aneurysm itself?
Well, the pathology of the aneurysm itself warrants deeper examination. Saccular aortic aneurysms are less common than fusiform aneurysms, which represent more generalized dilations of the aorta. However, saccular aneurysms are generally considered more prone to rupture due to the higher wall shear stress concentrated at the neck of the aneurysm, acting as a focal point of weakness. In this patient, the formation of the aneurysm and its subsequent rupture were attributed to a confluence of several critical contributing factors. One, his prior cardiac surgery, specifically the aortic cannulation during the VSC-ASC repair decades ago, likely created a localized structural weakness or predisposition. This was compounded by his chronic, poorly controlled hypertension, which imposed relentless systemic stress on the arterial walls, accelerating dilation and weakening. And then, furthermore, his polysubstance abuse did not help the situation at all, particularly the stimulants, significantly exacerbating the hypertension can directly damage the vascular endothelium. This creating a synergistic effect that predisposed him to an aneurysm progression and acute rupture. This case serves as a powerful illustration of the multifactorial pathology where various insults on vascular integrity over time converge to create a highly complex and unfortunately catastrophic cardiovascular event.
And hemodynamic impact of the aorto-right ventricular fistula must have been profound, right?
It was, Neel. A large fistula, such as one observed in this patient, results in a significant anatomic left-to-right shunt. This means that blood from the high-pressure aorta is shunted directly into the much lower-pressure right ventricle. This leads to acute right ventricular pressure and volume overload, causing a rapid right ventricular dilation, increased right ventricular wall stress, and ultimately acute right ventricular failure. This directly explained the sudden onset of cardiogenic shock. The right ventricle, unaccustomed to such a massive volume pressure load, was unable to maintain forward flow to the pulmonary circulatory system and subsequently to the left side of the heart, resulting in a systemic hypoperfusion and shock. The significantly increased RVSP observed on echocardiography, coupled with marked right ventricular dilation, served as a direct evidence of this overwhelming hemodynamic burden, demonstrating how an acute shunt can completely destabilize the cardiovascular system.
Absolutely. I mean, this case also vividly showcased the power and necessity of the multimodal imaging. Victoria, can you walk us through how each imaging modality contributed for the diagnosis?
Of course, Neil. Each imaging modality contributed uniquely to unraveling this mystery. I'll walk through the CT angiography. This was crucial for initially identifying and comprehensively characterizing the large saccular ascending aneurysm. It provided precise dimensions, revealed the layered thrombus, and helped to understand its anatomical relationship to surrounding structures. Furthermore, the CT's high spatial resolution and wide field of view are excellent for assessing the aorta and detecting aneurysms. But then that wasn't only the imaging modality that was utilized in this case. We also have the transthoracic and transesophageal echocardiography, also known as TTE or TEE. These modalities were absolutely crucial for the real-time diagnosis of the fistula during acute deterioration. Bedside echocardiography, particularly of TEE, allowed for visualization of the new continuous turbulent flow from the aorta directly into the right ventricle. Quantification of the acute right ventricular dilation, and estimation of significantly increased RVSP, all in a rapidly deteriorating patient. Its accessibility and real-time capabilities are unmatched for acute hemodynamic assessment and shunt detection. We also have the cardiac MRI, which was also utilized in this case, which provided additional tissue characterization of the aneurysm, confirming the partial thrombosis and, importantly, showing no significant late gadolinium enhancement, also known as LGE, in the myocardium. And this was reassuring regarding the absence of significant myocardial scar related to the aneurysm itself. CMR, cardiac MRI, offers a superior soft tissue characterization compared to CT, aiding in the differentiation of various tissue components within a mass or lesion. So, Jay, can you summarize the case to us?
In summary, this case highlights the complementary nature of these imaging modalities. While CT provided the initial anatomical roadmap of the aneurysm, echocardiography offered real-time hemodynamic assessment of the immediate diagnosis of the acute rupture and shunt. CMR contributed valuable tissue characterization. Each tool brought up something unique to the table, demonstrating that imaging choices are guided by the clinical question, the urgency of the situation, the availability of the imaging, and the specific information needed to make the critical management decisions.
Yeah, and given this catastrophic event unfolding, a ruptured aneurysm into the right ventricle a massive aorto-right ventricular fistula causing the cardiogenic shock. Jay, do you want to tell us what was the management strategy?
Given the catastrophic event unfolding, a ruptured aneurysm, a massive aorto-right ventricular fistula, and cardiogenic shock, the patient was emergently brought to the operating room for an extremely high-risk salvage aortic aneurysm repair surgery. Like we mentioned before, he was planned to do this the following day, but had to do it the previous night in an emergent situation. The urgency of the situation was obviously paramount, and the patient became markedly hemodynamically unstable immediately after anesthesia induction, and his systolic blood pressure dropping down to 50 millimeters mercury, necessitating the immediate initiation of external cardiopulmonary bypass via the right femoral artery and vein. This profound instability underscored the severity of his condition and the acuity of the rupture.
And Victoria, do you want to tell us what did the surgeons find intraoperatively?
Of course, Neil. I found this very interesting and fascinating. The cardiothoracic surgeons discovered a large 2 centimeter diameter hole in the anterior part of the ascending aorta, which communicated directly with the saccular aneurysm, layered with old and new thrombus. The fistula into the right ventricular outflow tract, also known as the RVOT area, was located just proximal to the pulmonic valve and presented a massive defect, measuring more than 4 to 5 centimeters, with several smaller holes evident after the removal of thrombus. This truly represented a complete blowout and an anatomical catastrophe. To repair the large opening in the right ventricular wall, a 5 by 10 centimeters bovine pericardial patch was meticulously chosen and sewn around the defect to eliminate the opening without narrowing the RVOT. For the aneurysm itself, a 5 centimeter segment of the ascending aorta was replaced by a 34 millimeter gel with straight graft.
Yeah, that's very interesting. And Jay, do you want to tell us what was the post-operative course for this patient?
Unfortunately, the patient's postoperative course was severely complicated. He developed severe coagulopathy with extensive bleeding that necessitated multiple rounds of blood products. Due to the ongoing oozing, a cabral fistula was utilized to drain blood into the right atrium. More critically, he experienced continued severe right ventricular dysfunction, which required the placement of a right ventricular assist device, or RVAD, with a 10 millimeter graft to the PDA and venous drainage from the right groin cannula. This indicated that even with anatomical repair, the right ventricle had sustained profound injury and was unable to recover its function independently. The patient remained critically ill in the ICU, requiring intravenous pressure support with the RVAD in place. Despite all resuscitative efforts, his hemodynamic function continued to decline postoperatively, and the bedside 2D echocardiogram showed severely depressed left ventricular function as well. This tragic outcome underscored the devastating impact of such a massive insult to the right ventricle. Even with the RVAD and aggressive support, his right ventricle was simply too injured to recover, and ultimately the left ventricle also succumbed. This sequence of events tragically demonstrates the extremely high mortality risk associated with such complex emergent cardiac surgical interventions, particularly when dealing with acute, severe, and refractory right ventricular failure. Ultimately, after extensive discussions with the family, further escalation of care was deemed futile, and the patient passed away due to refractory right heart failure and hemodynamic collapse soon after aggressive resuscitation measures were de-escalated. This outcome serves as a sobering reminder of the inherent limitations of even the most advanced medical and surgical interventions in the face of an overwhelming multi-organ failure.
Team, this was a really, really challenging case. And as you pointed out, almost unprecedented. And obviously, we are thinking about the patient and his family. So, you have a patient who comes in basically with syncope, encephalopathy, and you're trying to work them up, and you find the saccular aneurysm. You realize that you want to intervene on that. And as you're getting ready to intervene on that, he just has this dramatic decline in function, just going into frank cardiogenic shock, rapidly escalating troponins, hemodynamic lability and instability, and arrhythmia. And you jumped on that. You've excluded some of the usual problems associated with aortopathies, but you find this fistula into the RV. And just thinking about that RV was totally never ready for that systemic pressure. And we go from, normal RV pressures, as you pointed out, with the RVSP being normal on prior echo imaging, to all of a sudden just total exposure to the systemic pressures in this immediate setting. And so we understand why the patient had this rapid demise and decline. And of course, you and your institution did everything possible to help save him and change his course, but these could be challenging. I did see a case of aorta RV fistula after TAVR, and the outcome was similar. Really, it can be a very devastating problem because of that profound injury in such a short period of time. It's very hard to recover. Even in that case, the fistula was fixed percutaneously, but it was too late to reverse the damage that had been done and the associated injury to the body. So, with that in mind, and as we keep our patient in mind, what are some of the clinical pearls that we could take out from this case going forward to potentially make an impact in somebody's life?
Yeah, the first one is the saccular aortic aneurysms, while less common than their fusiform counterpart, they do carry a higher inherent rupture risk due to the increased wall shear stress concentrated at the specific points of weaknesses. The formation of such aneurysm can be multifactorial with prior cardiac surgery involving the aortic cannulation, chronic through controlled hypertension, and significantly polysubstance use, acting as a powerful and synergistic contributor to vascular fragility and the disease progression. Recognizing this complex interplay of risk factor is crucial for comprehensive patient assessment.
Second, the direct rupture of an aortic aneurysm into a cardiac chamber, especially the right ventricle, is an exceedingly rare event. As highlighted by this case, it was previously unreported in the literature. This underscores the unpredictable nature of complex aortic pathology and the critical importance of maintaining a broad differential and considering the unexpected when faced with acute cardiac emergency.
Third, the formation of a large aorto-right ventricular fistula results in a massive left to right shunt. This leads to acute right ventricular pressure and volume overload, culminating in rapid cardiogenic shock and refractory right ventricular failure. Recognizing the acute hemodynamic deterioration and promptly identifying its underlying cause is paramount for timely and effective intervention.
Fourth one being the multimodal imaging is indispensable for the rapid diagnosis and comprehensive characterization of such life-threatening cardiovascular emergencies. Each imaging modality, from the CT angiography for the initial anatomical identification of the aneurysm to the emergent echocardiography involving transthoracic and transesophageal echocardiography for the real-time hemodynamic assessment and the fistula detection, and the cardiac MRI with the detailed tissue characterization offers a unique insights that collectively build a complete and accurate clinical picture. The judicious use of these tools is critical in guiding the management decisions.
And finally, the emergent surgical repair of a ruptured aortic aneurysm with an aorto-right ventricular fistula is an extremely high-risk procedure associated with significant mortality. This emphasizes the critical need for rapid diagnosis, prompt multidisciplinary care involving intensive care, cardiology, and cardiothoracic surgery, and the importance of realistic expectations regarding outcomes in such catastrophic scenarios.
Thank you, Victoria. This case was truly humbling and profoundly educational, pushing our diagnostic and management skills to their limits. It serves as a powerful reminder of the sheer complexity and sometimes completely unexpected presentations of cardiovascular disease. It reinforces the importance of maintaining a broad differential, even when faced with seemingly straightforward symptoms, and the critical need to constantly reevaluate and integrate new information as the patient's condition rapidly evolves.
Ultimately, it highlights the incredible teamwork required in critical care settings. From the initial community hospital assessment to the tertiary care CVICU, the imaging specialists, and the cardiothoracic surgeons. Underscoring that managing such life-threatening emergencies is truly a collaborative endeavor.
Thank you, Victoria and Jay, for walking us through this incredibly educational case. And thank you, CardioNerds, for tuning in. We hope this discussion had equipped you with a deeper understanding of these complex cardiovascular challenges.
Stay tuned for more CardioNerds case reports.
And now I would like to introduce our faculty expert, Dr. Andrew Zurick, who is a cardiac imaging specialist, and he was involved in the care of this patient with me to give his comments.
Hello, this is Dr. Andrew Zurick. I'm a preventive and imaging cardiologist based at Ascension St. Thomas Heart in Nashville, Tennessee. I've been here for about 14 years. I help to head up the cardiac CT and MRI programs. I want to congratulate Neel and Victoria and Jay for a great presentation on the case that we're discussing today. I remember very clearly working with Neel when we were on service together on this case, and it served as a very good learning case from my perspective. This gentleman that we're talking about today is one of the common presentations that we'll encounter in medical practice of the patient found down, or we are uncertain as to what has led him to us. In this particular situation, we learned of a gentleman who had a history of polysubstance abuse with poorly controlled hypertension and some type of prior cardiac surgery, the exact details of which we did not have at the time that we first met him. But initial CT imaging of his chest did demonstrate a very large aneurysm of his ascending thoracic aorta that was partially thrombosed. We discussed his case with cardiac surgery, but due to his present situation, we felt that imminent surgery was not advisable. Unfortunately, he clinically decompensated, became hypotensive and bradycardic overnight, and he needed emergent placement of a transcutaneous pacemaker and was started on IV pressors for hemodynamic support. As a teaching point with Neel, we elected, because of electrical and hemodynamic instability, to obtain a bedside stat transthoracic echocardiogram to see if there was some explanation that would account for his clinical decline. The learning point that I found most impressive on this case was the use of color Doppler echo to advise us as to the reason for his clinical decompensation. And in a very unique turn, this gentleman actually ruptured his ascending aortic aneurysm into his right ventricle. This is an extremely rare form of rupture, and obviously most patients with aortic rupture don't live to tell the tale, but this gentleman did survive. What was most compelling was on his right ventricular inflow view on his echocardiogram, we could see a color Doppler jet that was entering the right ventricle from an area that would not be consistent with typical tricuspid valve regurgitation. Additionally, this color flow appeared most prominently in systole, but we did see evidence of color flow throughout the cardiac cycle, which would imply some type of continuous shunting. We then asked one of my partners to confirm with a transesophageal echocardiogram this communication between the aorta and right ventricle. Once this was confirmed, we then again rediscussed his case urgently with our cardiothoracic surgeons and felt that there was no choice with the new shunt plus a significant drop in his right ventricular systolic function, as well as RV dilation, that there was no choice for us to proceed urgently with surgery to repair his aorta. Intraoperatively, our cardiothoracic surgeons found a large 2-centimeter hole in the anterior portion of the ascending aorta, which likely was a result of prior cannulation from the cardiac surgery he had many years previously. Unfortunately, despite a significant heroic attempt by our cardiothoracic surgical team, this gentleman continued to decompensate postoperatively and ultimately had a right ventricular assist device placed along with a Cabral fistula. Despite this, he remained in the ICU on intensive support therapy and ultimately succumbed to multi-organ failure. What we felt like was such a unique aspect of this case was that it's not often that patients will survive aortic aneurysm ruptures. Even more interesting to have a patient rupture an aortic aneurysm into a cardiac chamber is also extremely rare, and there were very few case reports of this in the literature. This case obviously resulted in a massive left to right shunt, which this gentleman's right ventricle was not equipped to deal with, and ultimately resulted in his death. But the learning point for our fellows from this case was the importance of use of bedside quick echocardiographic imaging when patients have a decline in their cardiovascular status, either hemodynamically or electrocardiographically. use of bedside echo can be extremely useful. In this case, help to make the diagnosis as to what caused his clinical decline. So again, I want to congratulate Jay, Victoria, and Neel for a wonderful job putting this case together. Neel was an outstanding fellow, and this was a pleasure getting to work on this case with him. Thank you very much.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Pacey Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LeCom Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.